This video provides information on the mistreatment of elders and the different forms that mistreatment may take. This program also demonstrates how nurses and other healthcare professionals can use the Elder Assessment Instrument to screen for possible elder abuse.
Mrs. Schwartz is an 80-year-old female who presented to the emergency room this morning after being found on the floor by her home health attendant. Just a little bit about her medical background. She has a history significant for hypothyroidism, and she also has a history of pneumonia. She was actually in our hospital about a month ago. So she was found on the floor by her home attendant. She apparently got up to try to walk to the bathroom by herself last night, and she did rule in for a hip fracture on x-ray. A little bit about her background. She lives at home in her own apartment. She has 12 hours of home attendant service. And on her last admission, when I reviewed the chart, we had made special circumstances to get her discharged. She was able to have 12 hours of home attendant service, and her daughter had actually agreed to provide the other 12 hours of supervision in the home, so she wasn't going to be home. Our biggest concern when we discharged her last time was her ambulation.
Hi, Ms. Schwartz. My name's Donna. Just to remind you, I'm the geriatric nurse practitioner, and I'm here with Denise, the nursing student.
Hi.
Hi. Your nurse Janice had asked me to come in and see if I could ask you a few questions. Is now a good time to ask you a few questions?
Yes, I'm okay.
Now, Janice told me she gave you some pain medicine a few minutes ago. How's your pain doing?
It's a little better than it was.
Okay. So it's okay to proceed with a few
Yes,
questions?
yes.
Okay. Now, Ms. Schwartz, I remember you from a month ago when you were in the hospital. I think you were treated for a pneumonia.
Yes.
The doctor and the nurse were explaining to me that you fell last night and fractured your hip. Can you tell me a little bit about what happened last night?
I was alone, and I had to go to the bathroom.
Okay.
So it was not easy for me to get out of bed and get to the bathroom, and I tripped on the mat in front of the bathroom.
Okay. Now, they told me that your home attendant found you on the floor in the morning.
Yes.
You weren't able to get up by yourself?
No.
And there was no way for you to call for help?
I didn't have the phone with my normally I have my walk-around phone with me, but I didn't have it, and because my neighbors, we have sort of a buddy system, and
I see. That must have been very difficult for you.
yes.
Now, I'm going to ask you some questions. Everything you say to me is confidential. Is that okay?
Yes.
Now, a little bit about your living situation. Do you live by yourself?
Mostly. Yeah.
Mostly.
I had the aide, and some evenings my daughter comes.
Okay. What time in the morning? Do you know the hours that your aide is
She
there
works
with you?
from 8 to 8.
Okay. And what kind of things does she help you with?
She prepares my meals. She straightens up the house.
Okay.
Helps me with a shower.
Now, how do you do walking around by yourself?
I have a walker.
Okay.
That helps me, gives me the security.
Right. Have you ever fallen before that you remember?
Not really fallen where I've done damage to myself.
Okay. Does your home attendant or your aide, as you say, does she help you with your walking?
Yes.
Okay.
Yes.
And have you ever felt afraid walking by yourself?
I don't know if the word is afraid, but I suppose yes.
Okay. And you have one daughter. Does your daughter live in the same apartment building as you?
No.
Does she live nearby in the city?
Uptown.
She lives uptown. Does she work?
Yes.
She works. And you said that sometimes she spends the night with you. How often can you recall how often she spends the night with you? Or how often you're by yourself?
Maybe 1 or 2 nights, maybe.
Okay.
Not usually. Usually just comes to check in or check me out, or
Mrs. Schwartz, I just want to ask you a few more questions about how you're spending your evenings if you're by yourself. If you can't get to the toilet, or I know that last night you tried to get to the bathroom by yourself and fell, but have you ever had accidents?
Yes.
You have. And when that happens, you're laying in a wet bed all night?
I'm laying in a wet bed, yes. Embarrassed to death and laying in a wet bed.
Now, have you ever had problems where your skin has felt sore or you've been in any pain when you're lying in bed?
No.
No. Oh, that's good. Are you able to turn yourself side to side when you're lying in bed?
Yes, a little, yeah, a little.
Sometimes. Okay. Mrs. Schwartz, can I just ask you a little bit about your relationship with your daughter?
Sure.
How do you generally get along?
Pretty good.
Have you ever felt afraid of your daughter?
No.
Or have you ever felt intimidated by your daughter? Or
She tries sometimes to bust my chops, but I don't let.
have you ever been upset with her for not staying with you some nights?
Yes and no. I mean, when she can, she does it, and not have to fend for myself.
Just a few questions now about another sensitive subject, just your financial issues. Do you take care of your own money?
Yes, I do.
Okay. You're able to write your checks and
Yes.
to pay your bills?
Yes.
Have you ever been worried that somebody was using your money in an inappropriate way?
No.
Now, I remember working with yourself and your daughter on the last time you were in the hospital, and we had it arranged that,
She would be there.
and especially since we were so concerned that you weren't walking so well and really needed assistance getting
Yes.
around your apartment into the bathroom in particular.
Right.
What's changed that your daughter's not able to spend every night with you?
She has a quote-unquote social life. Whatever happens to me at home, I would rather be at home, whether I'm wet in bed or laying on the floor, than be in a nursing home.
I understand.
That's the way I feel.
I understand. Mrs. Schwartz, I want to thank you for the time that you've taken to answer the questions and sharing your time with Denise and I. We're going to go wash our hands, and we're going to be back in. We want to do a brief physical exam. Would that be okay?
Fine, yeah.
Okay. I bet after that fall last night, you might have some areas that are tender, or maybe a
Banged
little
up.
bruised.
Banged up, yeah.
Okay. I'm just going to take a look at your arms. Denise, we're just looking for some signs of bruising or anything on our arms. That's great. Just going to look at your other arm. Good. I'm happy to see you have a fall bracelet on. Mrs. Schwartz, this fall bracelet is something we put on to help the staff and everybody identify you as being someone who needs some assistance because you've had a fall last night and you're at high risk for falling again. I'm just looking at this arm. A little abrasions up on this arm. Great. Can you just open your mouth for me? Good. I'm just going to examine your legs, okay? I'm just going to pull the sheets from the bottom. Thanks, Denise. So we're just looking for any bruises, any tenderness. Yeah, a little sore there. Just make sure the pulses are there. Mrs. Schwartz, I know that you fractured your hip and you have some pain there. Denise and I are very carefully going to turn you onto the side because we need to inspect the skin on your back.
Okay.
We don't want you to do any work while we're turning, okay? We're going to do all the work for you, okay? Because we don't want you to move your legs, all right? So we're going to kind of turn you like a log turns, just all as one, okay?
Yes.
So what you can do is rest your arms on your chest just like you had them, okay? And we're going to very carefully turn you to the side. That's wonderful. And if you want to use that arm to support yourself on the rail, you can do that, and you can use that top one too. Great. Are you okay?
Yes.
Okay. Now, Denise, we just want to take a good look at her skin. Yeah, and we can see that area on the sacrum. It's red and a little bit excoriated. Like some of the skin has come off.
Should we measure it?
Yes. We're not going to measure it now, though. Okay. Denise, I'm going to support her back up here. Can you just take a look at her heels? Great. You just want to palpate that? Is that skin blanchable?
No, it's not actually.
Mrs. Schwartz, do you have any pain or tenderness anywhere?
No.
Nothing on your back?
No.
Okay. How about here on your sacrum? I'm palpating. Any discomfort?
No.
Okay. Okay, we're going to gently roll you back. If you can let go of that rail there, we're going to roll you back. Okay? Are you okay?
Yes.
All right. Thank you again for taking the time for us to do the assessment with you, okay? I really appreciate it.
Maybe you get the bill.
Thank you.
Janice, I want to thank you so much for referring Mrs. Schwartz to us for your concerns that you had this morning. It was a great opportunity to have Denise and I go in there and perform the EAI and do a screen for elder mistreatment. Something I really like about this tool is that it is a way for us to systematically assess for elder abuse. I think that it's very difficult for a nurse to miss an egregious case of abuse or mistreatment. But sometimes there are some subtler events, or neglect, for example, that could be easy to miss. So this tool kind of breaks it apart and lets us go through an assessment in a systematic way. The first section is the general assessment. And if you're looking at your tool right now, what we had found was significant in Mrs. Schwartz was her skin integrity. And we actually graded that as being poor. She did have a pressure ulcer on her sacrum, stage 2, and she also had bilateral stage 1s on her heels. So that's very concerning. And as Janice had mentioned before, this is a lady who's pretty ambulatory, although she does require assistance. The second section is titled Possible Abuse Indicators. And the one section here that we checked off as being possible for evidence of abuse or mistreatment or neglect, for that matter, is the fracture, that she did come in with an acute fracture. So in an older adult, that in and of itself is cause for some concern.
What about the abrasions that were on her upper right arm? Did that seem to you like a possible abuse?
One thing that was reassuring to me in doing this assessment is that her abrasions were unilateral. And that's something that we can kind of consider as being normal, knowing that she did have a fall, and to see some abrasions or lacerations on the side that she fell or would be involved in the fall is normal. If she had bilateral abrasions or bilateral bruising, that might be more cause for alarm, because that could be indicative of these injuries occurring on a more frequent basis as opposed to a one-time fall. Another assessment indicator that you want to pay close attention to in doing a skin assessment where you're suspecting that there might be some abuse going on is looking at bruises. If you have bruises on somebody's body that are of different stages of healing, for example, if some look like they were fresh bruises and like a deep purple, and some look like they were brown and old and healing, that might be something to cause a concern, because that might be, again, indicative of these injuries being done on a repeated basis or an ongoing basis. Under the third section, the possible neglect indicators, there were several indicators that we scored positive under possible evidence for neglect. These were decubiti, or pressure ulcers, and we know that she does have she has 3 pressure ulcers in total. Another area is urine burns. I'm not sure if they were urine burns or if definitely attributable to the pressure ulcers, but that's something that I'd want to check off as being something that's possible evidence for elder neglect. Poor hygiene, I think that this is also something with the urine burns and the pressure ulcers that we wanted to consider. Her repetitive hospitalizations. A hospitalization or rehospitalization after 1 month can be a cause for concern in an older adult, and she was just here last month.
I have some concerns about her nutritional status. She's a very picky eater from what I remember the last admission, and I have a feeling that we need to explore that because that might have some impact on how well she heals during this hospitalization, in particular with the pressure ulcer, and we're looking at dehydration with her as well.
That's a great point, Janice. And what we've done is we've sent off a pre-albumin level. So when that lab comes back, that'll give us a clearer picture of how her nutritional status is. And I've already put a consult in with the dietitian, so she can follow up as well. Now we're on section 4, which is the possible exploitation indicators. Exploitation is really difficult to assess with older adults. We did ask a few questions about her financial issues, and she seemed quite confident answering them, that she was able to still manage her money and that she did have a nephew that sometimes assisted. What we'll do with this when we meet with the geriatric team is to talk more to the social worker about this. She'll have a better ability to see what her financial issues are. So right now I haven't checked anything off as being any evidence of exploitation on that section. So now we're coming to section 5, which is the possible abandonment indicators, which is another form of elder mistreatment. This is, I think, where we captured a lot of Janice's concerns with initially why she initially referred the case to us for further assessment. I think that we definitely have some probable evidence there has been some withdrawal from care, that at one point Mrs. Schwartz's daughter was reliably spending evenings with her or reliably providing another home health attendant to spend evening with her, and this is no longer being done. Mrs. Schwartz had actually said that she thinks her daughter has more social activities now, which is preventing that. So we're going to check off that there is some probable evidence in that category. So just on the last section, which is the summary, and just wrapping up this EAI tool that we completed today. Under evidence of abuse, we're really going to say that there is no evidence. The fracture that occurred, I don't think, was evident of somebody directly abusing Mrs. Schwartz or intentionally meaning to do something to cause the actual injury. Evidence of neglect, I think that through that we have several indicators where we saw some possible evidence of neglect. So we're going to leave that under the possible evidence section and continue to explore that. Under the evidence of exploitation box, I think we're going to check that off in the unable to assess box for right now and wait for the social worker who can explore a little bit more into the financial aspects and has a little bit more access to that kind of information. Evidence of abandonment, right now I'm actually going to check the probable box for that there is some probable evidence, because I think that that's really the crux of our concern with the possible mistreatment that's going on, that there has been some abandonment and possibly some neglect going on. And when we present all this information to our geriatric care team, where we'll have the social worker and the geriatrician, they'll be able to give us some feedback on what our next step should be. Just a little bit more about her findings. She does have a left hip fracture. We're waiting for medical clearance to see if she's able to go for a hip repair. She was slightly dehydrated when she presented in the emergency room. She has a stage 2 pressure ulcer on her sacrum, and we found that she also had stage 1 heel ulcers on bilateral heels. Mrs. Schwartz has a big fear of winding up in a nursing home, and she actually said that to us this morning during the assessment.
The daughter said that she would be able to take care of her, but I want to make clear that she's not living with her at this point of time.
Right. They do have separate apartments, and I think that the daughter's plan was that she would spend most nights with her, or she would privately pay for a home attendant. Okay. But that the agreement was that the mother wasn't going to spend her nights alone.
You said that she did not want to go to the nursing home.
Yeah.
Most of the times, these are the scenarios where elder mistreatment does not obviously come up because they do not volunteer, because they do not want to lose their home.
She actually said she'd rather be on the floor, spend her night soaked in urine, than have to wind up in a nursing home. We found that very poignant and really evident of her fear of going to a nursing home. The daughter does work full-time, and we realized that this was going to kind of be a stretch, but the daughter did agree to provide the other 12 hours of home service. So this tool is really great because it really provides a systematic way for us to assess a patient and make sure that we're hitting on every indicator that could be possible areas of mistreatment or neglect, which might be the case in the case of Ms. Schwartz. The other areas that we weren't able to assess under the neglect indicators, which I look forward to your feedback on, and we definitely will need to revisit, is depression. She doesn't report any outward sadness, but I would think that we should go back and do a full geriatric depression scale. Also, medications. We didn't do a thorough medication evaluation with her yet, and her nutritional status. And I think that we've already put a consult into the dietitian, and we're waiting for a prealbumin level to come back. The section about the abandonment indicators is really my biggest concern, is that there does seem to be a little bit of a withdrawal of treatment or withdrawal of care that she was receiving. She mentions that her daughter's social life has gotten more active, and this might be a way of saying that she's not able to spend as many evenings there. And I think, as Janice had mentioned too, there's concerns that Mrs. Schwartz is uncomfortable with other caregivers, so maybe they're not trying to get other people in lieu of the daughter to come in. So that definitely needs some more exploration.
Donna, on that note, a question here, because the way this tool is worded, it has possible evidence, probable evidence, or definite evidence. In the case of Mrs. Schwartz, how would you rate that?
That's a great question. I think that's why this tool is so easy to use. You are able to use your clinical judgment and put her in a category that you think you feel comfortable with, and then go forward and bring it to the experts, which is really what we're doing now, and having this discussion with all the team members here.
So you would say with Mrs. Schwartz that it was possible?
I would say it was possible. I would also feel very confident knowing that you really can't score wrong. I think it's always better to err on the side of being cautious and put somebody in a category that we think they might be at risk, and then remove them from it later.
So it would be the most important thing is the safety of the patient.
Absolutely, and I think we'll all agree that's why we're here. We really want to make sure whatever we're doing for Mrs. Schwartz as she's getting ready to leave the hospital after we fix her up, that she's going to be safe in her environment.
There is a very fine line in knowing whether there is an abuse or neglect or abandonment. But what we want to look at is the final outcome. Is there a harm done or not? If a harm is done, whether the actions really intended to do the harm is not important, but the point is that there is a harm and we need to look at that. And again, as Donna said, it's always better to err on the suspicion rather than not act on what we find.
It would be a good thing to do to speak to the daughter and find out her side of the story so that we're not making any assumptions, but we're really trying to find out and do more of an investigation.
Also, we are talking about caregiver stress, and it's always very important to explore how much of a burden it is on a caregiver to take care of the elderly, and sometimes they collapse under the pressure, and that also attributes to some form of neglect. But if we can talk to them and see what harm they're doing by this, maybe we can help.
So the other areas that we wanted to look at was her pressure ulcer. I'm concerned that she has a stage 2 on her sacrum and the stage 1 on her heel. I'm worried that she's not moving a lot at night and she's lying in urine. Dr. Buddha, if you'll look at them with me later on, we can come up with a treatment plan. And once her pre-albumin comes back and the dietitian does a thorough assessment, we can figure out what's going on in that department.
With a hip fracture, usually there's some form of rehabilitation involved, and I'm wondering if she'd be a candidate for home PT or if she really would have to have some short-term treatment in a subacute rehab.
With that, you have to take a look at her environment, make sure that we do a home safety inspection, make sure she has adequate equipment so that we can prevent future fractures and other injuries that she can probably get into. So we need to take a look at her environment as well before she even gets rehab.
We can ask the rehab doctors to tell us if in certain areas whether a hip fracture can be also given a good PT at home rather than subacute. If not, then probably we'll have to sit with her and convince her that at least it's going to be a short term, and then we're going to put her back in the community and get further physical therapy.
That's a great point, because she really, and I'm sure she'll tell you again, Dr. Buddha, she just has a definite fear of being in a facility.
Sure.
So
it's very understandable.
We'll have to tread lightly and really explain to her that if she does require for subacute rehab, she'll be there for a short term, and that we do have a plan for her.
With this hip fracture and after she has the surgery, how long will her stay in the hospital be for?
The most important thing that we want to do is mobilize as soon as possible. The better they get out of the bed, we decrease the immobilization, and it's better for them to get back on their feet. So sooner the better. Right after the surgery, the physical therapy will be in, and they will make an assessment and try to get her to do some physical therapy.
Are we going to be able to put everything in place if this is neglect, if this is mistreatment? During this time, we'll be able to ascertain that and then take steps so that she doesn't go home to an environment or gets put in an environment where she's at risk. There will be enough time for that.
Yes.
It's important also to realize that her planning is not going to stop when she leaves the hospital doors. We have to make sure that she has supports via social work and via visiting nurse and physical therapy that are going to follow her in the community.
Julie, is there any way to evaluate before you have the meeting with the family if she's like even a candidate for like increased services, like maybe 24-hour services, as opposed to the 12 that she had, being that she's in another category since she's had an injury?
Based on her financial issues, and that's why we're going to take a look at that as well, and her insurance, what insurance she has. We'll see if she's a candidate for more hours. And then we'll also follow up with the family, see if there are nephews or other people who might be available to also assist the daughter in taking care of the patient. So we'll try to look at all of our options, Janice, and see what we can do for the patient to make sure that she's in a safe environment and that she's in a happy environment as well.
Donna, just to bring us back to where we were, just to use the tools that we're going to be using for Mrs. Schwartz, I understand that we're going to use the Caregiver Strain Index for her daughter, and then we'll also be doing the Geriatric Depression Scale. Is that right, on Mrs. Schwartz?
That's great.
Okay, so those are the two tools that we'll be using.
Right, and that sounds like a good plan. So we're just going to sum up Mrs. Schwartz's case by saying that the next step is going to be for Julie to call the daughter and get a meeting. And I think the first step is going to be meeting with the daughter by herself and doing a little bit more exploration, and then seeing, we might be able to bring the team back together with Mrs. Schwartz and the daughter and figure out what the discharge plan will be. It'd be good to see them interact also. Anything else on Mrs. Schwartz? No. All right, great. So we'll get moving on to the next patient.
Years ago, you would not think about elder mistreatment. It wasn't in the reporting laws. Older people were very hidden. They were considered hidden victims in the early elder mistreatment literature. And as we've made progress, and I will say that nurses have been at the forefront of that progress when you look at the literature, we know now that it can be that nurse in the emergency room, that nurse in the admissions department that screens the patient and really gets them on a track immediately toward safety and toward better care. In the past, if an older person came in with urine burns or excoriations, it was written off to old age. You know, that's a geriatric patient, that's a Gomer. That's what they look like. What do you expect, Terry? They're old. Well, we know we can expect a lot more than that. And when you have two older people who, for all intents and purposes, have about the same clinical profile, why on earth would it be okay for someone to come in disheveled, dirty, with skin breakdown and dehydration, and the other one to come in without those features and not ask yourself, that's not disease. What is that? It could be neglect or abuse. It's estimated that about 4% of older adults in this country are victims of elder mistreatment. So it's a serious and prevalent problem. It could be 700,000 to 1.2 million people at a minimum each year who are victims of this horrific environmental, interpersonal conflict. Best practices for elder mistreatment can be as simple as the following. If every nurse, as a part of their practice, said, is there any family violence or any elder abuse or neglect you'd like to tell me about, they would have done an enormous service to their patient in order to help them express some of their concerns that they might have and are afraid to comment on. People tell me that it's a hard question to ask, but I will remember the 1970s where it was very hard to ask, for example, a quadriplegic about their sexual functioning. As a profession, that's what we do. We ask difficult questions, and the question of elder mistreatment has got to be a part of the health assessment. Is there any elder mistreatment you'd like to tell me about? And then work with them in order to expand on the question and create a care plan. As a part of best practice, I'm a huge advocate for our elder assessment instrument, which has been in the literature since 1984. And it's a screen that we use to look at the theoretical and clinical domains that are thought to be a part of this constellation, this geriatric syndrome. It's a 41-item instrument that we use to look at, for example, whether or not an older individual is highly dependent on another person for caregiving, which the literature would suggest puts one in more risk for inadequate care or elder mistreatment or neglect. We look at physical signs and symptoms, and so there's a physical assessment component that looks at whether or not the individual has bruising, bleeding, lacerations, urine burns, for example, that are unexplained by the diagnosis and the reason for admission. And we also always, within the context of this instrument, always ask the patient, would you like to tell me if there's any abuse, any neglect? Because the subjective complaint is equally important to follow up. It's very important that a nurse never miss the subjective complaint of any type of elder mistreatment, that in the course of a history, that there's a question about any type of family violence, and that it's pursued. If there's child abuse, for example, in a family, it's important to understand whether there's also domestic violence, elder mistreatment. We say where there's smoke, there's fire, and in some families, there can be very troubling circumstances that comes out in violent tactics. And so it's very important not to miss the clues that are given in a history. Then with the physical, it's very important to think through whether or not the presentation of the older person is consistent with the diseases, disorders, and the chief complaint that the patient's coming to the clinical setting with at that point in time. So if an individual were to tell you that they bumped themselves and they really couldn't account for it, but you could see clear finger marks on somebody's upper arm, for example, that can't be overlooked. And similarly, I think about older individuals who come in with any kind of battering around their upper torso or head. It is not common for older people to fall without any break in their fall. It can happen, but you have to ask yourself, is it usual to see bilateral bruising? It's not. This assessment can be done by nurses, nursing assistants with partnership with the nurses with whom they work, can be done by physicians, can be done by social workers. Generally speaking, it's best done in a team approach where you bring together the interdisciplinary geriatric team and everybody weighs in on their perspective around what they know about that patient. This assessment takes between 12 and 15 minutes for those people who use it on some regular basis. The elder assessment instrument was created in order to facilitate the practice of busy clinicians when they suspect something's wrong but they don't have the advanced knowledge or background to determine whether something is a case or is not a case of elder mistreatment. So therefore, when I think about the nurses I work with in emergency rooms when we're training and using the EAI, they will be comfortable saying that they believe there's evidence of a symptom, but they're less comfortable saying, so I know this is a case of elder mistreatment. And that's right. They wait until they can refer to either an expert in the hospital, which might be a geriatrician or a geriatric nurse practitioner or geriatric social worker, or they might work with their hospital administrator to reach out to the adult protective service system across the United States. Patients take these questions as a matter of course. They trust nurses, they trust the healthcare system, they believe that we're there for them, and when you engage in this discussion, they participate. In the 20-plus years that I've been conducting elder abuse screens or interviews, I can count on less than 2 hands the number of times patients say, I don't want to discuss this, or please stop asking me this. It's much more the case that they'll say, I do want to talk to you about this, and what will we do about it? The dilemma comes when an older person tells you about elder abuse and they say, but please don't tell anybody. So it's very important for a nurse to get in the conversation quickly that, I want to talk to you about this, and certainly we might have to share it with other people. so that you can be honest and have truth-telling to your patient, but at the same time encourage them to be forthcoming. It's a balance. Another challenge that comes with administering the EAI is when you have a family member or caregiver present, and it may be that individual who is the person doing the elder mistreatment. In that case, it's important to separate the older individual from that person so that you can have a private conversation. That can be very tricky because family members, friends, caregivers are anxious when they step out. And they are also anxious, particularly if there's elder mistreatment, they're anxious that the patient might say something that would, quote unquote, get them in trouble. And so that's a tricky part. And it's important to think about how you will have privacy with the patient while not alarming the caregiver to the extent that it could later create problems in that system. I'm really pleased with the progress we've made on generating resources that can help a busy nurse in their practice with regard to elder mistreatment. Certainly our Hartford Institute for Geriatric Nursing website is one that we believe is extremely helpful, and also the AJN series and the materials that have been developed for this series are exceptional and can really get to the heart of the matter for individuals who have so much information to assimilate every day in their practice. Additionally, the National Institute on Aging has been the champion of this issue in terms of generating the research base we need to inform our practice. An additional resource is the National Center on Elder Abuse, which is an organization that's been funded by the Department of Health and Human Services and is very good in terms of helping busy clinicians find the information they need for this area of practice.